Good evening, everybody. My name is Trevor Dean. It is my honour and great pleasure to welcome you all inside St Vincent's as we explore and reflect on 25 years of transforming epilepsy care. Whether you're a long-time supporter of St Vincent's, a patient or family member, clinician or researcher, or someone with a personal connection to epilepsy, we are grateful to each of you for sharing this evening with us. Tonight recognises the role philanthropy has played and continues to play. And as we look to the future of healthcare, we know philanthropy support is even more vital. So on behalf of St Vincent's Foundation Victoria, we gratefully and officially tonight launch our fundraising appeal in support of our neurology department. Many of you here tonight have already helped make progress just like this possible. And for this, we thank you. Thank you for your generosity, and thank you for continuing to stand beside our clinicians, our researchers, and our patients. It's my pleasure now to introduce our facilitator for this evening. Matt Preston is one of Australia's most recognisable media personalities, author, journalist, and broadcaster, and someone with his own personal connection to epilepsy.
Epilepsy is something that touched my family. 40 years ago, my brother died of sudden, unexpected death in epilepsy. So I'm familiar from that side of it. That side as the family member of a patient with epilepsy and the impact that worst case scenario can have. See, one of the things before I started working on the hospital, when I talked to different people in the neurology space, the one thing they said is that money was tighter in neurology than any other area. It's not what you tend to see in neurology is that fundraising doesn't come from government funds. It tends to come from family members who've been affected with it. It doesn't matter whether it's MMD or Parkinson's or epilepsy. It tends to come from people like you. So thank you very much indeed for being here. So let us introduce our panel. Start with the professor. Professor Mark Cook, AO, is Director of Neurosciences at St Vincent's Hospital, Melbourne, and one of Australia's leading experts in epilepsy research and treatment. Dr. Amy Halliday is a neurologist at St Vincent's whose work focuses on caring for patients living with epilepsy and other neurological conditions. And Mr. Christian Bullis is a neurosurgeon at St Vincent's Private Hospital, Fitzroy, specialising in complex neurological procedures, including epilepsy surgery. Please welcome our panel. Mark, let's start with you. What exactly is epilepsy?
Well, epilepsy is probably best thought of as a small short circuit on the surface of the brain. The brain's a big circuit board, and small short circuits stop areas of the brain functioning normally, and that's what we understand as seizures. Most people think of seizures as collapse and convulsion, but most seizures are blank episodes where people zone out for a minute or two, but that's where the danger is and what stops them getting on with life.
What is the day-to-day impact on people with epilepsy?
Everyone's different, but if you're intermittently losing awareness, that might sound like a small problem if it only happens for a few minutes, several times a week or a month or whatever. But that stops you driving a car, stops you working, stops you caring for your kids. So I think my favourite definition of epilepsy is it's the bits in between. So people with epilepsy live in a state of continuous dread. That it's the seizures are troublesome, but it's the bit in between the apprehension, the fear of what might happen, having a seizure in public. That's what disables people.
And a seizure every 7 minutes, what does that level of activity mean for both physically and emotionally for a patient?
It's not difficult to imagine how much of an impact it has on somebody's life. Even the bits in between are not quality bits. So the brain has sent you offline, you've only just recovered and it's hitting you again. At the moment, we don't have any way to know when that seizure is going to happen, and it's the uncertainty that carries all of the disability. And it stops you, it makes you second guess everything you're going to do today.
What's the impact on the families?
Well, it's really a generational issue. I mean, you look at the young patient, their parents are caring for them. It's not unusual for parents to sleep in the same room as a child just to make sure they don't have a seizure during the night and they're there ready, waiting, and it impacts their ability to work, those parents. Then as the patient gets older, it affects their siblings and their partners. And so their partners are like the safety net. So all these family members, it's really impacting their lives. Then finally, I mean, these young patients are, particularly women, trying to have children with epilepsy. And so the medications, they're worried about the impact that might have on their developing baby. then flow through to when they have this young child that if they have a seizure and suddenly they can't care for the baby if there's no one else around.
What the most significant things that have changed over the last 20 years?
Well, the technological advances have been very dramatic, obviously, and in the early days, the changes in imaging and our ability to localise things, and Christian would be able to speak better to this, but the stereotactic guided systems based on MRI, it's equivalent from going from a Melways to going to maps on your phone. But in fact, the biggest difference to me has been having people come along like Amy and Christian, because they bring a new level of skill and expertise and innovation.
Are we just sort of starting to discover quite how complex this is?
Absolutely, and there are so many factors involved, but I guess, again, the change has been that there's interest in it. And even amongst neurologists, the epilepsy clinic used to be the place people didn't want to go and work. That has changed dramatically. So it's an area that people want to be involved in. So much is happening, new treatments, new drugs, new surgical techniques, better understanding of the causes.
Hello everyone, my name's Danny. I live in southwest rural Victoria, and this is my story. During the peak of my epilepsy, I was having a seizure approximately every 7 minutes, 24 hours a day, 7 days a week. The seizures affecting my life. I didn't drive a car for, nearly a decade. Seizures are exhausting, so it was like if I felt really tired, I wouldn't cut the vegetables because the risk of losing a finger was relevant. I wouldn't shower unless my husband was home or somebody was in the house with me. And as a 40-year-old woman, I couldn't swim unsupervised. So yeah, it affected every aspect of my life. When I met Mark, he was the third neurologist I had come to visit. For the first time I felt heard. I felt like here is someone who genuinely cared. Having the brain surgery, I was actually told there was only a 2% chance of success. I took that anyway. I thought, well, better to have something than nothing. I mean, just think, if you'd gone that far and then just pulled out because it might be 2%, it was worth the chance. But on top of that, and foremost, I trusted Mark. I trusted my team. With my life now being seizure-free, it means I can regain control of the activities I once felt passionate about. Being seizure-free also means I can have a normal life. I don't have to be scared about spilling the coffee at the cafe. Reclaiming my life has meant to me I'm full again. I can live without the fear of all those things. I can do things that I used to do, but most of all, it's changed my perspective. And to me, perspective is what life used to be as to what life is now.
The technology is everything because it's a disease of the brain. And to be honest, these days, now that we've got imaging, we can better work out if there's a smoking gun on the scan, and if that's causing the mischief, I can take that out and maybe you don't need to take the tablets anymore. But for 2/3 of the patients, it's take the tablets, see if they work, and they do. For the other third, it's take the tablets, see if they work, and they don't. See what else we can do. I've got no way of telling if they're on the right tablet until they have a seizure, and then I find out actually it wasn't. And we should be doing better for those patients too, because they deserve a better journey to finding the right tablet. That's all going to be driven by technology. To be able to measure what the brain's doing today, rather than wait for seizures to happen. Seizure diaries are pretty woeful. 1/3 of patients underreport, 1/3 over-report, and 1/3 are random. So we need better, more objective treatment markers and biomarkers of brain activity rather than just relying on patient self-report.
How has technology helped you, given making certain less invasive?
I suppose when patients come and are considering an operation, which is a pretty big deal, there's 3 main areas that they're interested in. What's the success of making their seizures better or ideally curing? How long is my recovery going to be? And what's the consequence of removing that part of the brain? That's all they're interested in, really. And so the technology used in the operating theatre is trying to improve all those quantifications of those risks.
Talk about that surgery you did where you're actually placing those sensors in the brain.
So when a patient comes to be worked up in a hospital for epilepsy, what Mark and Amy will do, we'll put a a cap over their head with a number of little electrodes to work out the electrical activity and see what is abnormal. And so often that has 30 of those little individual wires plugged into the brain. And then when we isolate part of the brain that wants to be, we're considering operating, we will put about 15 electrodes in one part of the brain that has over 15 electrodes in it. So it's like 150 electrodes in just one part. So you can see the fidelity of that is so much higher than what the first patient had. I mean, and this is what we're trying to do to minimize the amount of brain that we need to remove to get a good outcome.
15 years ago, we did a study where we put a device inside people's head to count seizure activity accurately for the first time ever over very long periods of time rather than just in hospital for a few hours or days. And we were able to see that there were very complicated patterns to seizure activity, but they could be identified, that they were very unique to each individual. But once you collect enough data, you could actually start to forecast seizures for them. So you can have the technology and have all of that sorted out, but making it actually useful to people is another matter, and that's something we're very heavily involved in at the moment. So seizure forecasting, we can actually tell people when they're going to have seizures and treat them only when necessary, would be beautiful.
Christian, from a surgical perspective, how much safer is brain surgery these days?
The advancements in technology, which we keep coming back to, has found other sources that we wouldn't have seen 20 years ago. And so these small little kindling spots that like start the bushfire we're seeing now and trying to remove with little, especially with the more advanced understanding the network within the brain and where the electricity passes through. I mean, these are the game changers from my point of view, and patients that were 20 years ago wouldn't have been eligible for an operation and suddenly have this chance to be off their medication seizure free.
One of the great things about doing this filming with Danny is that it's been about 5 years since she had that surgery. So it was wonderful to see her again after such a big break and see what she's doing. For a lot of them, I don't get to see what they do 10 years later because they're not my patient anymore, which is great. But the ones that I have seen, and it's so humbling to see these people so grateful that for what you've done. And, you know, some of them, their marriage was really in trouble and they've moved back into their parents because they've got 2 small kids at home and they feel unsafe around their kids. You see them again and their kids are teenagers and their marriage is great and they're going on holidays overseas. It's so humbling to hear them talk about everyday life. And it's humbling because you realise how much you take it for granted.
Mark, how do you feel when you get these good outcomes?
I think probably the most dramatic thing a patient said to me was when I asked her what difference it made, she said, well, I've got my own friends now.
Hammy, your appeal this year is helping fund equipment like the high-density EEG caps and portable video EEG systems. Can you explain in practical terms how this technology improves experience and outcomes for patients?
We can put caps on the head that have 128 or 256 dots. That's enough data that we can triangulate where seizures are coming from within the brain when we match it up to that person's MRI. So that takes it from temporal lobe to sort of a cubic centimetre of where seizures might be coming from, which is a really important part of planning for that procedure that Danny had, where we implant electrodes in the brain to work out where seizures are coming from. So we can put the electrodes in exactly the right place and then do the thermocoagulation in that place. The home video EEG system means that patients can have brainwave recordings with video done at home. Our waiting list to have that done in hospital at the moment is 6 to 9 months. Being able to do that at home would mean that for patients that don't need their medications changed for us to catch their seizures, A, it means it reduces the waiting list to them to about 3 months, and B, it means our inpatient waiting list for video monitoring reduces to about 3 months. When patients are in their home environment, the yield is much better because they're sleeping normally, they're eating their usual things, taking their tablets at the usual times, so their usual seizures happen. In hospital, it's not unusual for somebody to have been waiting 18 months to have this video EEG done, but they come into hospital and nothing happens.
You mentioned the thermocoagulation. Can you explain what that is to people who...
Procedure that Danny had was stereo EEG, which is what Christian discussed earlier, where patients go into the operating theatre and have electrodes implanted in the brain for us to record directly from the brain where seizures are coming from. That's really important for patients who we know seizures are coming from around here somewhere, but the MRI scan is normal, so we can't just on spec go and cut something out. We need to prove where seizures are coming from before we can offer them potential curative surgery. But before they come out, we can do a small burn through some of those electrodes. And temporarily around those, there's some swelling that's a bit larger, the size of a pea for each burn that we do. And that swelling goes away, but while it's there, it sends that area of the brain offline for a while, including seizures. So we get to have almost like a bit of a test run of their surgery that they could have later on. And if seizures go away temporarily with that burn, the chance of being seizure-free if we cut that out later is huge. And a surprising number of patients are ending up seizure-free long-term, even after that swelling goes away, just with the burn they're left with. And we think it's because of all of the other testing that we do, the other technology we have with the high-density EEG caps, our fMRI scanning, our PET scan and special analysis of the PET scans. So I think our outcomes with the thermocoagulation are better than they should be because we're on the money more often.
Christian, what's the biggest unmet need for you?
So when I look at the equipment that I used back then compared to what's used now, it's a game changer. And so I think really the key now for epilepsy going forward is both getting more information and analysing that information to put into practical points so we can work out where it's coming from.
What's for you the biggest excitement?
Being able to collect this sort of information and analyse it on a massive scale like we can now, whether it be through the stereo EEG or like we spoke about before, collecting information over very long periods of time so you can forecast seizures. It's the same sort of problem. Before, not only could we not collect it, we couldn't analyse it even if we had collected it, but now we can do both. So you feel like you're in a big cave and someone's just given you a powerful flashlight and for the first time you're able to see your way around. Now, you can do these incredibly precise things. You can put electrodes into very small areas of brain and destroy very small areas of tissue and fix things.
Mark, what's the most exciting thing that's going to happen in the next decade?
Well, I think even more sophisticated, minimally invasive technologies. You know, there's the MR lit, as you've heard, there's the stereo EEG, and our ability to understand the data we're collecting now and act on it with the dramatic outcomes we're seeing now and the dramatically reduced risks. We're just going to see that keep increasing over the next decade.
Christian, and what's your greatest hope?
I think there's work in Melbourne now looking at genes in epilepsy. And so the genes are changing within parts of the brain. So ideally, if we can modify that gene by some technique just in that part of the brain, that will hopefully mitigate the need for medication that affects the whole brain. Melbourne is at the forefront of epilepsy research. So people come to Melbourne to learn about epilepsy just from people like Mark and Amy and other centres around Melbourne.
How important is that collaboration between researchers and clinicians and technology partners?
It's vital. It's vital. I did research. I did neuroscience degree and did research before I did medicine. There aren't too many people in my position who've experienced both. And when I talk to researchers, I can see how helpful it is to have a clinical understanding and have my own patients with epilepsy and hear them tell me what their needs are and know for myself what their needs are. I talk to clinicians who are doing clinical research and I can see that they haven't really learnt the rigour of the scientific method. We're lucky at St Vincent's to have the University of Melbourne and have a clinical school and a Department of Medicine on the hospital campus, and the engineers, the bioengineers, biomedical engineers are embedded in the hospital grounds where their education and research is really integrated with ours. And when we have stereo EEG, we have the engineers come and meet the patients and they're in theatre with us and doing research at the bedside.
Before I let you go, there's a message for you.
To the beautiful people who support the hospital, thank you. Sorry. I just get emotional. Thank you. Your kindness, thoughtfulness, and generosity ensured my neurology team had everything they needed to regain my future. I'm sorry I couldn't be here with you all tonight to thank you personally. Mark leads an amazing team. As individuals, they all provide the care, comfort, and respect to their patients. And I was one of the lucky ones to be in their care. Even when I was told the brain surgery only had a 2% chance of success, I never gave up. I had these amazing people right there with me, and I never doubted them, not for 1 second. And here I am, living a seizure-free life. But none of this would have been possible without wonderful people like you supporting St Vincent's and the amazing neurology team led by Mark. My wish is for patients like me to get the chance to live fulfilling lives without waiting for the next seizure to take it all away. Your gift to Mark's neurology team meant he could give me the gift of healing, and know this gift is not lost on me. And my gratitude to you all overwhelms me. I was one of the lucky ones. Thank you. It's emotional.